Good evening, everyone.
Right or whatever.
No, the next speaker is Dr. Kalpana Mehta. Requires no introduction. Everyone knows her. She is professor and head department of nephrology, the TN Medical College and Nair Hospital, Mumbai. She is teaching and clinical nephrology experience of more than 30 years. Initiated DM nephrology at the TN Medical College, Mumbai. His many research papers, and there is the first ABO compatible kidney transplant in Public Health Institute, Maharashtra. I request Madam for presentation.
Yeah. Good evening, everybody. We'll start with the topic. Can we have the slide presentation? I wanted the presentation in. So, good evening, everybody. There's a declining trend of incidence of pregnancy-related AKI in developing countries, but still it accounts for around 5 to 20% of total AKI population. Now, this is our own case studies where we had 70 cases of kidney dysfunction in pregnancies, which were about 2 years, which has been accepted by AJKD. And if you see, the most common causes of AKI in pregnancy were pre-eclampsia and sepsis, around 25 out of 70. So the importance of this pregnancy-related AKI is obviously because of immediate affection on mother, involvement of maternal mortality, which is almost in our group was 18.2%, and the fetal mortality was almost 50%. We all know the definition of pre-eclampsia, and I will not waste time on it. It's a combination of hypertension and proteinuria. And we also know that in the absence of proteinuria, with new onset, one can diagnose and label pre-eclampsia. With new onset hypertension, with new onset of any of the following, these are the warning signs which I would read it out because they are important. Thrombocytopenia less than 1 lakh. Renal insufficiency with creatinine of more than 1.1 or doubling of the creatinine in the absence of other renal disease. Transaminase liver more than twice, pulmonary edema or cerebral or visual symptoms. Now coming to pathophysiology of preeclampsia, the 3 most vital organs affected are kidney, liver and brain. And it is a disease of maternal endothelium with widespread endothelial dysfunction, with vasoconstriction of all majority of important end organs. And this causative role of placenta in the hypoperfusion is all known to us again, because we have seen this is happening in the medical conditions with vascular insufficiency like diabetes and SLE. Also, there is increased conditions like hydatidiform mole and twin pregnancies, where there is an increase in the placental mass, but without any corresponding increase of blood flow. Not only that, even at high altitude, the preeclampsia incidence is higher. Now, normally, when there is a placental vascular remodeling, normally the invading tropocytoblast will take the maternal endothelial phenotype leading into the good large capacitance vessel. But in preeclampsia, though there is invaginous cytotropoblast, it fails to acquire the endothelial phenotype, resulting into the small capacitance and high resistance vessel. Now, if you look at the placenta, which in the preeclamptic woman, this is what it will show. It will show the changes of acute atherosis, which is usually with the macrophages laden with fat and the oil stain showing the red globules of the fat, with changes of intimal thickening, necrosis, atherosclerosis, and so forth. So if you come to a pathophysiology in short, because I can't really cover up every aspect in that time, but there are multiple factors responsible for it. One of them, which is said, is the oxidative stress. Now, the oxidative radicals have been found in preeclamptic women, but whether it really has a causative role or whether it is just a secondary phenomenon, and it has no clinical relevance in the treatment. Same thing applies for the inflammation. The debris of cytotropoblast has been seen in the circulation causing the inflammation and is said to be responsible for the severe vasoconstriction. Immune intolerance to fetus is another next factor which has been considered, and that is said to be because of one is a HLA-G which is present in the syncytial tropoblast are important for this immune tolerance, and it is minimally expressed in this woman. Also, the NK cells which are responsible for the vasculogenesis are usually abnormal. So these two together leading to immune intolerance and another pathophysiological factor. Also, the agonistic autoantibodies against AT1 receptors has been seen in these patients, in this preeclamptic women, which stimulate AT1 receptor leading to increased sensitivity to angiotensin 1 and again vasoconstriction. Beyond that, of course, there are other factors which have been said, including angiogenic factor which come to it, which are increased in this patient. And so these changes are seen prior to onset of hypertension and proteinuria, and not only that, it persists years after preeclampsia episode. So this is what we are talking about. The most promising pathophysiology which has been brought forth and has been used now is the angiogenic imbalance. Now we have the angiogenic factor which is VGEF and anti-angiogenic factor SFLT and endoglin. Now there is upregulation of SFLT in placenta and there are increased levels of it which inhibits angiogenesis. And this is said to be the circulating pathogenic toxin in preeclamptic women. Now, the maternal serum levels of SFLT1 and endoglin both rise to prior to preeclampsia onset. So, what are the renal changes in preeclampsia? Now, we all again know, and it has been documented, is that primary glomerular target in preeclampsia is endothelial cell. And VGEF is important for the health of the endothelium. And this is VGEF is expressed by glomerular podocyte as well as endothelial cells. And early in the course, the podocyte is normal, but in later course, in particularly severe cases, podocyturia is seen. And if you look at the postmortem reports and the renal autopsy, there is reduced expression of nephrin in this patient. So, if you look at the renal histopathology, because of endothelial swelling, which you call it endotheliosis, with the bloodless glomerulus seen, and on the EM, one will see the fibrillar material, some endothelially placed. In severe preeclampsia and eclampsia, one can almost get, apart from bloodless glomeruli, the changes almost like early thrombotic microangiopathy. So, the AKI in preeclampsia is because of two main reasons: fall in GFR because of increased afferent arterial resistance and because of decreased ultrafiltration coefficient because of endotheliosis. And preeclampsia is the most common cause of AKI in pregnancy. But the DFR decreases is less than 30 to 40%, and requirement of renal replacement therapy is uncommon unless it is with severe preeclampsia or associated with HELP, which usually has abruptio placenta and coagulopathy, or there is severe PPH or sepsis. And this AKI has been accounted in HELP is almost around 3 to 15%, more towards 15% if HELP is there along with it. So can one prevent the preeclampsia or detect it early? And that is the thumb rule, that early detection, monitoring and supportive care is most important, with risk assessment in early pregnancy. And this is what we see at Public Health Institute, the patients which are referred from periphery, absolutely not much monitoring, and hence they land up in the very poor state. Adequate antenatal care is very important, because in women with no underlying disease, preeclampsia will be 5%. But if with high risk, it also straight jumps to 25%. So risk assessment early in the pregnancy is very important. Frequent monitoring after 20 weeks of gestation for hypertension, proteinuria, headache, visual disturbances, and epigastric pain must be looked out for. Uterine arterial Doppler or fetoplacental monitoring has a prediction of sensitivity and specificity of 65 to 85% and should be used and have been used at many centers. Now, next important now is the serum biomarkers. There are many, but what is used mainly is the ratio of SFLT1 by placental growth factor. Now, this has a negative predictive value of 100% as quoted in this study. And the significance of these markers, and especially this ratio, is that it is early detects, precede the clinical onset of preeclampsia weeks prior, higher in severe preeclampsia, higher in those with adverse outcome, and it also helps to differentiate from other diseases. So, can we prevent with aspirin? As per the literature, the low dose aspirin around 81 milligram per day has been the practice advisory by this group. And this has been given between 12 to 28 weeks and continued until the delivery. And these are the ones where they have used in these patients. As per the practical advisory, our common risk factors of multi-fetal gestation, chronic hypertension, kidney disease, diabetes, autoimmune diseases, any one of this, or one of the multiple factors in this, one of more moderate risk factors, including small for gestation, low birth weight babies, previous adverse outcome, family history, which are very important for us. What about the role of calcium? This has been studied again in these two studies. In this particular study, they have used it for patients who have the basal calcium intake of less than 600. The dose given was more than 1 gram per day, and they found there was a significant reduction in preeclampsia risk. And this was tested by this group, and they found there was no difference in incidence of preeclampsia, but there was low rate of eclampsia, complications of preeclampsia, gestational hypertension, and neonatal mortality. What about the LMWH? Now the 15 studies which were studied here in RCT, the conclusion is that there is a significant reduction in the risk of preeclampsia and other placenta mediated complication when started before 16 weeks. And if it is combined with low dose aspirin, it is still further significant in reducing the risk of preeclampsia. I will not again go into more details. All of us are well known with which drug to use and which are the contraindicated drugs. But BP should not be lowered too much because we don't want fetal or maternal complications because of low blood pressure. What most important I would like to focus that the treatment is, all of us again know, is the delivery, the prompt delivery. Right? If it is less than that, so generalization can be made, which cannot be always apply for all. Less than 24 weeks of gestation, termination of the pregnancy, because the complications in severe preeclampsia is more than 80% for the fetus and very high complications in mother. More than 37 weeks, immediate delivery. But in the gray zone between the two, potential neonatal benefit of continuing pregnancy versus possibility of maternal complication in delaying delivery, one has to consider. We have not used it, but dextran sulfate apheresis, which has been used presently for familial hyperlipidemia, has been used in 11 women, which have helped in the very preterm preeclampsia with the ratio of more than 85, and there was 81% reduction in the markers, improvement in proteinuria, and prolongation of the pregnancy. Is there any role of therapeutic plasma exchange in preeclampsia and health? No, because this will delay the treatment. What is required is prompt delivery in this. But having said that, if the maternal condition doesn't improve in 72 hours, that is of course queries, the period which we say golden period observed, and if there is worsening during that period, then one must consider TPE along with the looking out for the causes for it. And we as clinician, all of us are aware how difficult it is, and notoriously many times, to differentiate between preeclampsia and TMA, many times. So I quickly go through 3-4 cases. All of them have the almost severe presentation. This lady, gravida 4, 36 weeks, all warning signs with high BP, creatinine which went from 0.6 to 2.3, proteinuria, Doppler showing severe placenta insufficiency, high LDH, high GOT-PT, low platelets, right? Now, we always, these 5 syndromes which can happen in pregnancy with the similar syndrome, that is TTP, HUS, acute fatty liver of pregnancy, acute phospholipid syndrome, and SLE. Now, this lady's cystocytes were negative, induced labor, improved markedly. So, obviously, she was a severe preeclampsia with HELLP syndrome, AKI, complete recovery. But the point to be noted that she was detected to be hypertensive first time in the fourth pregnancy, and hence will need very close follow-up. This case, of course, it is not always so easy that everything is preeclampsia and AKI, as has seen by in this case. And she is a lady which is 27-year-old, third gravida, came, was somewhere else, 8 months of gestation, hypertension, diminished vision, fluid overload, low HB, low high count, platelet low, LDH normal, HGOT-PT as a 60-39, creatinine went from 1.9 to 5 and almost became dialysis dependent, was given antibiotics. And this is a CT scan of hers showing typical features of acute cortical necrosis. And the concern the hospital wherever she was outside, had labeled her as acute cortical necrosis, which was secondary to severe postpartum hemorrhage and sepsis together, apart from she being hypertensive and proteinuria earlier. And she was referred to us for transplant 3 months later. Now here was the patient where before taking her for transplant, we did her C3 nephrotic factor and anti-CH50 and including genetic test, where we did clinical exome, which was negative for 6675 genes. And here we lose the graft on third day. And the biopsy showed TMA without any other causes of antibody-mediated rejection. So one has to be always alert when dealing with these cases. This was again bad obstetric history, seizures, high BP, IUFB this time again not evaluated in type of 2 to 3 loss of pregnancies earlier, and she turned out to be APLA positive, right? So these are the important factors one must remember while evaluating preeclampsia with AKI. And this is my last part of the talk, that what is the role, what should nephrologists evaluate the patient in long run is the follow-up required with nephrologists. So I'll look into these 3 parts. Looking at the recurrence of preeclampsia. Now this is the study in BMC in 2009 where 7 lakhs plus primary mothers were evaluated with 21,000 multiple gestations. And if you look at that, what is the recurrence of preeclampsia? If the first pregnancy, no preeclampsia, 1.1. If second pregnancy, preeclampsia, 14%. And if both the pregnancies, first and second have, then it's almost 31.9%. Now, the preeclampsia women who have early and severe preeclampsia have the greatest risk of recurrence, that is 25 to 65%. While those who come with mild preeclampsia in late pregnancy have 5 to 7%. So it is said that these two, late mild and early severe preeclampsia, might differ etiologically, and early onset preeclampsia being affected by risk factors like genetic and environmental factor and has familial aggregations and more complications. What about cardiovascular disease after preeclampsia? Now, in this, it has been said that there's a graded relationship in this journal, American Heart Journal, between the severity of preeclampsia and the risk of future cardiac disease. And as one goes from mild preeclampsia to severe preeclampsia, the risk of cardiovascular disease increases too. And that also includes not only hypertension, stroke, thrombosis, as well as peripheral artery disease. And the last is that cardiovascular disease after preeclampsia is highest with early onset preeclampsia, early onset severe preeclampsia, recurrent preeclampsia, or gestational hypertension, or preeclampsia with onset as multipara as the highest risk. And the last is end-stage renal disease after pregnancy, those who develop preeclampsia. So microalbuminuria has been seen in almost after 3 to 5 years who develop from preeclampsia is around 23 milligram per day, while in control group it is 6.7 milligram. Those with preeclampsia with offspring weight of less than 1.5 kg have a higher incidence of kidney biopsy in mother, and the incidence of 3.7 per 1 lakh women per year of ESRD was noted in the NEJM from medical birth history of Norway. So this is the last slide. Post preeclampsia is follow-up required with nephrologist. Yes, not all. Women with early onset severe preeclampsia, recurrent preeclampsia, gestational hypertension, or preeclampsia with onset as multipara for the first time. Thank you.
Thank you, madam, for covering this complicated topic so nicely. But you had made our life complicated by how to give this 81 milligram of aspirin. Thank you. Now topic is open for discussion.
Actually, I have cut down many slides because I had to finish it in so-called 17 times. So, आपण मराठीत म्हणतो वाक पाठी लागल्यासारखं, so I had to really control it. There are other studies which have used 150 milligram. And in fact, when they have used 150 milligram, they have used the biophysical algorithm, looking at the mean arterial pressure, even looking at the SFLT1. These multiple factors were combined together, and I agree, 81, they have said 81, but it is, have been also mentioned as 150 in some of the studies.
Madam, it's a very excellent presentation, the complicated topic. But only problem patient presents with the third trimester pre-eclampsia with AKI, and usually comes with the IUD, some patient in ICU. Now, how to differentiate with the different entity, like this is due to pre-eclampsia, TTP, HUS? Because if you do the peripheral smear, histiocyte you not usually seen.
Yes.
That is the clinical spectrum is so overlapping. How to go ahead with these patients?
Yeah, actually, that is the reason those three cases which we put it together. It is very difficult because TMA will have its own presentation, as we said, with hemolytic activity. Same thing applies with HELP also. I mean, preeclampsia with HELP will also have the similar features. So, only way is a prompt delivery, which is many times difficult to convince gynecologists because patient has thrombocytopenia and all those things, right? So, and these patients, the best thing is prompt delivery. After prompt delivery, if there is no improvement, as it is said, wait for 72 hours, but it is very difficult many times. We have, again, I would resist one case where the patient improved in the sense creatinine started showing downward trend with increased urine output and everything, and she went out of radar, right? And only when was referred back with proteinuria 4+, and which was biopsy showing acute cortical necrosis again with TME, and the genetic studies also turn out to be positive, right? So it is, that's what I'm saying, it should start very early detection, try for prevention. Those hypertension should be looked into. If they, most of them, they come towards end age with creatinine of 2.5, they have a regular good follow-up, and in spite of that, sir, it will be difficult at many times, and only the prompt delivery, which is treatment, observe, if not, go for TPE, and simultaneously start working for the other causes of non-placental TMA or HUS.
Question from audience. Any comment?
Thank you.
Thank you, ma'am, for accepting this.
Thank you, ma'am, for in-depth discussion on pregnancy, preeclampsia and AKI.